Good morning, Dr. Labani. This is your patient Mark. You had asked a question about implant treatment planning and how we go about doing that with the Anatomage software, and also gaining some knowledge on whether or not we need to do bone grafting or not. So I'm going to walk you through the exercise here so that we can answer both of those simultaneously. Mark is a edentulous patient in the posterior mandible. So the first thing I want to do is go to the implant tab, like so, and then click on Pano Implant. I like placing the implants better in this module. Let's go ahead and do something like this. The specific tooth numbers are not that important. The reason it may become important, there are default settings that we can program in here so that every implant that we place in Site 27 will be this kind of implant with these heights and widths. If we decide to do that, that's fine. I think in the meantime, just placing them and then adjusting each individual implant separately, I think has some value at this stage in the game. All right, so I'm going to do something like that. One may ask, how many implants do we place? Lots of clinicians will say first molar occlusion is more than a patient needs. It also gets more difficult to place implants in the second molar areas. With that said, this patient doesn't have an upper second molar. So I think in this situation, we're going to be safe with just 2 implants. With that said, if you wanted to place a second implant here and splint the 3 implants together, a third implant, I would splint the implants together and do a splinted bridge. Reason I would maybe consider splinting here is because of the fact that the patient lost their lower teeth. When you see a presentation like this, you have to ask yourself the question, how did the patient lose those teeth? Parafunction would be my guess. Parafunction combined with poor oral hygiene and a high caries risk. With that said, all of his teeth had the same hygiene risk profile. All of the teeth had the same kariogenic profile, yet only the posterior lower teeth suffered a demise. I can't say for sure, but I think it's the parafunction in those areas that's important. Why is that relevant now? Because it dictates how you're going to build the structure at which the new teeth are going to be supported on. If there's an environment, that environment is likely to continue. The stormy weather in this guy's mouth, i.e. parafunction, is likely to continue. As a result, I would maybe consider adding an additional implant here. You and I can spend more time talking about that, but the topic of this video is more about what we're doing in the planning processes with implants. So I place the 3 like so. I'm also going to ignore this radio-opaque lesion here. You and I have talked about this, and we will be dealing with it accordingly. I'm going to go ahead and place the implants on the other side. Again, 2 is probably sufficient, but let's just have the discussion about what 3 would be like as we start to unravel this. All right, so I have the implants placed in the pano section. I can stay here to bring them parallel, so I have tools to change the position of the implant, but I typically go right over to 3-dimensional implant at this point. You don't need to do this. You can do everything that you need to do in that previous view. But I'll then come over here and ask myself the question, where do I want the implant to go in relation to the tooth next door? This patient will not be receiving a surgical guide for a variety of reasons. I think this is a wonderful case for you to plan a very well executed freehanding approach. What we'll do is we'll put the implants approximately where we think they'll be, but we're not going to go to the level of execution that we would if we were going to do a surgical guide with this. So if you decide to do a surgical guide, we can do that. We would just need a scan after you are finished with the Invisalign and the lower arch and finished with the PMMAs, because the surgical guide needs to be made on the teeth as they are. Otherwise, the guide wouldn't fit. And because we're doing so much with this patient moving forward, I don't think there's a point in time we're going to be able to pause it long enough to do all that we need to do. Plus, I think you can pull this off very well freehand. We're going to use the full flap approach so that you can get full visibility to see this ridge, and he has plenty of bone. I just don't think it's a case we need to do a surgical guide. So I'm going to place that first implant roughly 2 millimeters away from this adjacent tooth. 1.5 is the closest you want to get. There is a point at which we would get too far away. The farther away from the adjacent tooth, the stronger the emergence profile has to be on the crown. So you can imagine that when the crown starts at the platform of the implant, the farther it has to go in a mesial distal direction, the more exaggerated that area needs to be so that we close the contact point. So we don't want to go too far away because that creates prosthetic challenges that also increase the risk of food impaction underneath. So where we place this particular implant is important. 2 to 3 millimeters would be perfect. All right, so something like that. I then come in and re-angulate this accordingly to the root next door. And I'm also interested in angling the implant so that it opposes the functional cusp of the opposing dentition. We don't always have that. In this case, we do. I want to make sure that this implant is angled to intersect with the functional cusp in a normal occlusion with the opposing tooth. This little circle here is what we use for that. Something like that. And we don't have to get too stuck on this. A lot of times we can't do it because of the way the bone is. But let's just say you do that and the bone comes like this. That's when you graft. So the answer to your question, when do you graft? When you place an ideal implant and the amount of available bone that will allow you to place that implant in that position is severely deficient. Now, if we did that and there was a little bit of exposed threads on this planned implant, then maybe we're just going to move the implant over like so to get it within the bone. It doesn't make sense when we have the ability to move the implant to put the patient through significant ridge augmentation. Each ridge or each site for ridge augmentation runs the patient anywhere between $3,000 and $5,000 and anywhere between 6 and 12 months of healing. Not to mention it's technically challenging. The outcomes sometimes aren't ideal. If we can, we try to avoid doing ridge augmentation. In addition, we can do small amounts of augmentation to the implant site at the time of implant placement. I'm less keen on that because it requires quite a few things to go well. And I think for the early clinician, we should not rely on that particular technique. If you do, let's do it together. Let's use PRF. Let's use proper membranes. Let's use periosteal releases. There's lots of things that can tilt the scales in our favor to make that successful. If you take implant courses, it's not uncommon that they're going to say that's one of the easiest things to do. Sure, it's easy to do, but those who say it's easy clearly aren't laying a flap to see how much bone they actually got after the fact. They're just calling it success because nothing bad happened. That's not success. That's just ignorance towards an outcome. I would guarantee that those lecturers that are out there that talk about how easy it is to graft around an implant, just slap a membrane on, clearly are not looking at the outcomes. Guaranteed. With that said, there's maybe some that do it very well, but they're not slapping the bone there. They're doing a lot of steps to make sure that that bone is stabilized. My favorite way of doing it right now is a titanium mesh membrane that lives over the top of the implant and comes down like so, and the membrane is screwed into the implant. That provides a high degree of rigidity for the little amount of bone that you might put on the buccal surface of the implant. With that said, these are all different techniques and tools in the toolbox that we have. Your question was more, when do I know I need to graft? Well, we have this case here. This is as good of a site as we will see. We can place this implant wherever we want so that it opposes the opposing dentition. Some may say that we try to get this circle into the center of occlusion. That's not always easy to do. Personally, I would leave it right about there. We don't want to tilt this implant too far and then run the risk of overloading the implant in an axial direction just to achieve a screw access hole opposing the central occlusal of the opposing dentition. I like it right here. With that said, if you decide to splint these together, then you have more of a green light to do something like this. But do you need to idealize the angle of the implant if they're splinted? No, you don't need to do that because the 3 implants will act as a unit, or 2 implants if you decide to splint them. Here, just for the exercise sake, I want to try to do this in a non-splinted manner. So let's have the discussion about if this implant was by itself, what would we do? There's your answer right there. All right, we have plenty of bone. We don't need a graft there. Then I go to the next implant. What's the distance between 2 implants? What's the minimal distance between 2 implants? The answer is 3 millimeters. I think 3 millimeters is the answer. It's not just the minimum, it's the maximum. You really want to try to get these close to each other because of the fact that you want to minimize. Let me reselect the implant here and bring this over. That's what I wanted. We want to minimize the amount of prosthetics that needs to occur between these 2 teeth. What do I mean by that? Just like we were talked about when we were trying to put the implant next to the natural tooth at a distance that's close enough so you have a natural emergence profile of the crown so that the soft tissue around it has natural contours. That same holds true here. The closer you put the implants together, the easier it is to have emergence profiles that support proper soft tissue between the implants. The reason why we can't bring the 2 implants closer than 3 millimeters to each other has to do with the fact that we start to minimize the blood supply between the 2 implants, and we run the risk of having crestal bone loss. Somebody some time ago, it might have been Mish, measured that distance, and 3 millimeters is where we are. I wouldn't be surprised if that changes or gets more defined over time. That's where I place things, and I've had good success with bone level implants. Tissue level implants, you might have to have a different conversation, but we don't place those here with any routine consistency. So 3 millimeters, and then I'm also going to do the same here. I can't see the other implants in this view because this isn't far enough down. This view here is the orthogonal view to this line right here. So the more I bring this down, the more I can see the other implant. What I would do, here's the middle implant. I would take the measuring tool and go like this. And then bring this implant up against it. Now we're going to do this in the mouth. It's not important for you to get these exact unless you plan on making a surgical guide. But we're doing a test run here in the digital world so that when you get in the mouth, you know exactly the kind of bone you have. You're super fortunate here. This guy has more bone than most. It's just not likely that you're going to get this level or this degree of bone. With that said, let's play with what we have and let's choose the best implants for the situation. So now that I have the implants more or less in the right spots, I can now say I don't need to graft. So I'm going to come back over here and then say what implant would be ideal. I'm going to keep it in the generic realm for now, and I'm going to choose a diameter that best suits the needs of the case. It might be true that wider is better, but the answer is always more complex than that. Keep in mind that the wider you go, the more you take away from the available width of the bone. Why is that important? The blood supply around an implant comes from the cancellous bone mostly that surrounds an implant. If I make this very wide, just for illustrative purposes, I have now lost cancellous bone on the outside of the more coronal threads of the implant. So although it might be true that this beefier implant might be more structurally sound, lots of studies have shown that 4mm implants, 4 to 4.5, are just as strong as an implant of this size. We could get into the whole discussion about size of implants. I really don't want to waste any time on this video for that. Suffice it to say, wider isn't always better when it comes to treatment planning. All right, so let's just say 4mm. Do we have good cancellous bone around the implant? Yes. Again, this is a very rare ridge. You're very much fortunate with this particular patient. It's not always the case. So let's just say we go with a 4mm implant plus or minus 0.5, probably more on the 4.5 side than 3.5. As we get into the 3.5 and the 3.0mm implants, we start to talk about implants that are structurally less favorable. You're more likely to get fractures with those implants. You could splint here, you could do all kinds of things, but the topic of conversation is what implants are best for this guy. 4.0 to 4.5, up to 5. I think 5 might be the answer. Something like that. All right, so that's that first implant. That's pretty uncommon for a premolar. With that said, if you can do it and you have good cancellous bone around it, go ahead and do it. Now that I've widened this implant, I might want to change where it is in the mesial distal direction. So let's go over to this image here. I've now locked in this implant. I'm happy where it is. I'm now going to say 3mm from there. What does the bone look like? I have to click on the implant. Now I can move it. And it's 3mm from the crest, not necessarily 3mm from some apical dimension. That hasn't been studied, but my personal belief is that your most important cancellous bone is around the neck of the implant, and that's where the 3mm rule comes in. With that said, we're going to try to make them parallel here. There's our 3mm. Now, what is the size implant that might best serve our needs here? Let's just go to 4.5 and see what we have. I'm happy with that. It's pretty uncommon that you're going to have wider bone in the premolar area than where you have the implants placed in the posterior. With that said, I think this looks pretty good. So we're going to say 3.5, or sorry, 4.5, and then bring that implant out. All right. Now we're going to do the same thing on the final. Again, lots of bone, uncommon. Let's go 4.5 here also. Now, is it necessary, if we splint these implants, to keep that implant parallel with these? And the answer is no. I will often place this implant, something like this, so that you can get the drill in there. A lot of times this patient has upper teeth that prevent you from getting this second molar implant more upright. I'm sorry. These are molars. I misspoke. Yeah, we don't need 3 implants here. But let's just say that was the case, that you needed an additional implant back here. You can place it at an angle and potentially splint them together so that they're all one unit. But let's go ahead and delete this. All right, that'll serve the patient very well. So let's come to the other side. Sometimes the software doesn't place the implant in the ridge. Depending on how you do it, sometimes it places it in the vertebral column. But I think we're going to get the same outcome here. right, there's our implant. Look at the nice bone. I'm going to place this as such. Do the same here. Let's just say that's where the ideal implant was going to go. That's the kind of situation where I would say maybe let's just graft a little bit at the time of implant placement. Many surgeons would simply just maybe bring the implant here and mow down the ridge. Obviously, this has a lot to do with where the nerve is. That's the nerve right there, so we're very far away. That would be the easiest way to do it. You submerge the placement of the implant, but then you flatten the ridge so that you get that cancellous bone right here. Okay. As you do that, you do increase the crown to implant ratio, but crown to implant ratio is not the same thing conceptually as the crown to root ratio of a natural tooth. Mish talks a lot about this in his texts. With that said, I think clinically, if you control the occlusion very well, you can have a very strong crown to implant ratio. I don't think you're approaching anything here of any significance. I think 2-to-1 is really where you're starting to worry. 1-to-1, which would violate most tooth-borne situations, 1-to-1 implant to crown ratio is fairly common and highly successful. I don't have a command of the literature in this department that's up to date from what Mish originally said. With that said, that's definitely something we need to make sure that we understand very well. This case here, we're really not in the area of concern. So I would place the implant like so. As far as the width goes, you can have the same discussion that we had before, something like 4.5, 4 millimeters being the goal, if we can. Something like that. All right. We could play around with the distances between the teeth and the implants here. We're going to do that in the mouth at the day of surgery. All right. There is software in here that allows us to place the restorations. There's all kinds of libraries we can choose from. Let's just say we wanted to add teeth and see what they look like. Something like this. You can do this first and then you put the implants where they need to go so that they go through the occlusal table of the anticipated tooth. The old way of doing this was to do a wax up and then you would make a surgical guide based off that wax up. We can do that in the digital world now, something like this. And then we come back over to the implant view and we can see, we should be able to see the outline of the tooth. Let me see why that didn't happen. Yeah, I'm not sure why they're not transferring over. I'll have to find that answer. But you can add teeth, and then you come over to the implant view. Then you'll see an outline right here of the anticipated tooth, and then you make sure that the implant falls in the center of that. I kind of just skip it and I say if I have opposing occlusion, the opposing occlusion is what's going to dictate the tooth. Why put a tooth in if I just use if I know what the end is, then I can just skip the whole wax up part. With that said, there are many times it's super helpful to use that tool. So let's get good together at using that restoration tab. I'm going to look for a case that has a ridge deficiency so that we can have a better discussion about when to graft, but I think you get the idea. You place the implant so that it's in an ideal position, and then you ask yourself, am I far away from, do I have sufficient bone to support the implant in that position? If you're very far away from it and you can't move the implant to kind of smudge it into place, then you're going to want to graft. That's kind of the take-home message. So hopefully this helps. I will do another case here if I can find one, but play around with all of the tools that you learned today and let me know if you have any further questions. Thank you.